early tendinopathy, is it different from the chronic one? Is the topic of the session today. And the short answer is, I don't know. I know a lot about developing early tendinopathy. So the lecture will be a little bit more what happens when they develop the tendinopathy, the phase of developing. And so hopefully the other speakers will tell us more about small details, what happens in the cell, and so on. So the main question here is what happens when you're starting with a group of athletes and something happens. And we spend a lot of time, a lot of effort in identifying risk factors. And yesterday we spoke a little bit about ultrasound as a tool, and my conclusion is that it doesn't work as a tool for screening. It works for other things, but not for screening. So we talk a little bit more about what happens in this phase, and what's the difference between the athletes, and why some is coping with the load and the matches and the training, and why others don't. So first of all, when when they asked me to hold the presentation, I thought early tendinopathy means in children. So I ended up with a lot of slides about tendinopathy in children. So I had to get rid of all these slides, but I remained one. Because it's a little bit important when you start reading. Because this is one of my favorite topics when I'm having a couple of beers, is that because we know a lot about skeleton age, okay? So, but what about the same in tendon age? So the developing in the tendon. So don't get me started because I don't know anything about it, but I'm really interested in that topic. But if you're going to the children, we're having the Sinding Larsen Johansen, I think it's called in Norwegian. And it looks more or less like a jumper's knee. But it's called what we call apophysit, entesopathie, you know, the Slatters, the Iselin, the Sever, the same thing. So in this picture, because if I Googled it, like you do when you're having a lecture, they showed me this picture. That looks pretty much as an tendinopathy tendon. This one looks a little bit different because they had this something in the bone of the patella. We had a lot of issues about when we're starting the cohort Christian mentioned. I will of course get back to it. Would these have the Sinding Larsen disease? But when they were aged, was 16 and a half, 15.8, something like that, they didn't. So they are a bit younger and they are in a growth spurt. That was a lot of effort in young age, and we get back to what happens in the process of developing tendinopathy. So there's some way a process. This is just one model trying to describe it, and it's now 10 years old. But I sometimes use it because it's a little bit optimistic when you are in phase one. When you have a reactive tendon, you know, they are a little bit optimistic that it's possible to go back to a normal tendon. So that's a good thing when we're having early tendinopathy. Then it's a potential here. So these are just what happens inside the tendon, and it's a model of describing the whole process from the early tendinopathy to the chronic one. And these are also what happens in the phase of classical old picture of normal tendon, abnormal tendon, and we know for sure that it's multifactorial, the cause or the risk for the tendinopathy. So we had this group, you know, and we had a lot of them, counting them, a lot of developing, and we were able to identify a lot of risk factors. And so far we are not able to prevent it, but we are researchers, and we are very good at identifying risk factors. So we concluded after this year that we are destroying the most talented players. That's the conclusion of our study. 30% of the boys in a setting, in a sports gymnasium setting, are developing jumper's knee. 10% of the girls. And these are the talented athletes that with the technical skills, the physical capacity to become a really good athlete. And the key question is, how many teams should your talent play for? Because we know that load managing is central for the risk of developing. And the number of athletes leaving the sport is unknown. And we know these athletes are ending up with a reduced function because they have pain during the sports. But also in this group, we have this copers, non-copers, people dealing with a pain or dealing with a jumper's knee and a change in tendon. And now if I later on will end up a little bit philosophical in this, so is it about the top copers and the non-copers in the jumper's knee world? Briefly summarize, boarding school, 3 years, collecting data in 5 years, about 70 volleyball players each year. Twice a year, we're ending up with a lot of players. This is one of the flow charts, and you can see we had around, this is for 4-year data, 140 athletes, and around 30 developed jumper's knee. Just to summarize the risk factors. So if you're having the athlete, you're having the team, you are now the physio for a team. You are going to identify, and you're now trying to not developing early tendinopathy. So the risk factor is gender, that's clear. Male are in higher risk than females. Most cohorts or studies are identifying the male. We did one analysis later on. We are counting number of jumps during training. And actually we found that, actually there was the Barr family in charge of that article. And we found that the boys jumped 3 times more than the girls during a regular week of training. So actually it was a little bit interesting, because then is it only about the sex, or is it actually that they train different? Well, however, tendon load is what you need. It's match exposure and the training. And we get back to previous training and present training, because the historical training also matters. And I will talk more about that. Jumping ability, ultrasound findings, and our risk factors. Body composition we didn't find in these groups, and also it's don't play volleyball on concrete, but that's an old story. So let's focus on the training volume a little bit. That's a risk factor, and this is the most exciting. If you train a lot, you develop tendinopathy. Okay, we have identified that, we're sure for that. But what about this? This is what they trained before they started school. We thought that the athletes increasing the amount of training had a higher risk. So actually for us it was a bit surprising that the athletes developing jumper's knee had trained the most. Okay, they were the most trained athletes when they started at this special place. And then they increased the load around 40 to 50%. But all increased the load 40 to 50%. But these athletes had already trained a lot. And still, so they were not fit enough. Or maybe the developing of jumper's knee is more about the total load. So at a certain point, there is enough. That's a philosophical thing, but that was a very interesting finding. So we have the clinical here, you have the adaptation to the mechanical loading, you have the tendon and the muscles. And we are in one way dealing, this is one way of describing what happens, and you are in the phase here. And the threshold, for sure, is different from athlete to athlete. And every week I struggle, and you know that for sure, that patients are really different. And when you're doing surgery, it's like, I think I'm doing exactly the same thing. And they are behaving totally different in 9 months, 1 year afterwards. So for sure this is different, and trying to identify the factors which is to the level of that one would be very interesting. So let's bring some cases again. This is not the cases I presented yesterday. This is just showing the baseline score. So we tested them every 6 months. So in the phase they were having the tendinopathy in the middle, of course. We just asked them, did it start in November and October? But these are the visa score of one of the players. And he developed in jumper's knee after 2 years. And that's rare, because the common thing when you're going to a setting, where they are increasing the load 50%, training a lot, is that the people not tolerating it will develop in jumper's knee around we had 7 months, a half a year after they started the school. So for me, for these guys, I really don't understand if he's going 2.5 years or 2 years before developing jumper's knee. What was okay the first year, 1.5 year, and why? Why? I struggle with, in Norwegian we say, dråpen som får begeret å renne over. In English is the last straw that breaks the camel's back. Okay, and is that what happened here? After 2.5 years, or did he go to a really hard training camp in Eastern Europe where they played on really hard surface? Or we really don't know. So we're not so good at being precise at these data. This athlete he's more or her is a more common athlete. Really happy when she starts at school. She's not happy later on. And the visa score, it's when we are really about 50, life is not good. Okay, you can play volleyball at 75, 80 and having a lot of pain, but when you are 50, you're not able to do any sports, and life is not fun for a 16, 17-year-old girl. So as you can see, and as I told you later on, she continued at the school, and 6 months, more or less the same problem, and then she were able to cope a little bit with the problem. So she probably had some treatment, or she had load management, and the pain decreased, and she was able to do more. And this one is another one. When she started school, I met her 3 weeks after she started school. She had a lot of pain, and I was like, but there was moving around in the knee, so I didn't understand. But after 6 months, she coped with her training, and she was happy. And that's another, the soreness in the knee compared to the early tendinopathy, which is also very difficult. And this one we had yesterday, so this, why it's a lot of ultrasound. But he also quite happy and developed jumper's knee around 12 months or 6 months. You see, no, this one here. Something happened in this phase. And that's also what happened, and why did it happen after 1 year. So, and now we're up to the psychological factors, but I really don't know anything about it, but it's about the focus of the athletes. And the best athletes had the most pain, and the athletes with most pain and best function become professional in this material. And I really know you can blow them on the knee, and they would scream, So they were really painful tendons. So they had a tradition for, we cannot cure this, so why should I focus on the pain, or why should I focus on jumper's knee? Because you are not a good doctor, you are not a good physio. So let's put it far away and don't focus on the pain, and let's do what we really want. And that you see in some athletes, while others are feeling too much or something. You understand, you all understand, I think, what I'm meaning. So this is one of the area it would be interesting to look more into, the differences in these aspects. The physios, they are much more optimistic than me, okay? They are, that's very good. It's very important that you know your physiotherapist. High quality gives good results. And of course, the physios are meeting these athletes in much early phase, the early tendinopathy. And then hopefully in this phase, they are able to change it or make it go away or make it cope with it at least. So for me, I'm a surgeon now. I had this study, and today I'm a surgeon working in a hospital, and I'm always ending up with a third opinion jumper's knee athletes with at least a couple of years of symptoms. And they are coming and are really desperate, and what should I do? And then we ask about, should we do some surgery, because that's what I know. And even though I am a surgeon, I only operate very, very few of these athletes, because when I go into details and ask them about actually what they've done, I'm not satisfied. So then I turn them around and send them to a physio I know the name of and said, say hello for me. And that would be a challenge to the physio, and they would accept it, and these athletes would not come back. So that's very good to have the name of the physio and have the cooperation of, like, okay, he's coming. I will not give him the satisfaction of operating these patients. And that's a good thing. That's cooperation. So this one I presented 1 year ago, 2 years ago, about the volleyball player, and we ended up because he was crying and he was fed up and so on. And I sent him to a colleague because he's a friend of mine, so I didn't want to do it. So he actually become good. So that's my sunshine story of surgery, but I really don't do it that much. But I will learn a little bit more from Håkan, and then I will become good. So the take-home message from this is that early tendinopathy, the slow process, is difficult. And is it just den dråpen or the straw? Or is it an incidence? Because when you meet them, you have two different settings. You have the slowly progress, or you have a sudden onset of something, maybe a tournament in a weekend. Even though some people can talk about the jump, and then they felt something change. That might be two different things. So, and also there's the cutoff of the tendinopathy versus soreness and pain is very difficult in this phase. But in a research setting, we normally use the cutoff of 3 months, and that's what I did in the studies. And when I was meeting them as a researcher, I just hoped them developing jumper's knee. I didn't try to turn them around as you would do as a clinician. Thank you.
Thank you very much, Håvard. And now I will actually continue to present some data also we just published on early tendinopathy. So before I go on with the presentation, I would like to just acknowledge my many good colleagues and also collaborators, Peter Magnusson, René Svensson, Peter Scherling, and Michael Kerr, and of course Peter Tran, who is the first author on these data, and Nikolaj Malmgaard, who has also been very important in the data that I'm presenting, and of course Håvard Visnes, and least but not last, Rikke Høffner, who's also going to present in the last part of the session today. So when we look at the literature and the reason why we went into looking into early tendinopathy, there I can say to the beginning that chronic tendinopathy has been looked very much into many studies are published on this area. But as we look into the literature also, we must say that there's rare. There's not many studies there. So the most of the literature actually lies in this area, I would say, on this figure. But also we have some literature looking into the early phase, or the I would say before it actually develops into a tendinopathy. So as Håvard actually said, so what I'm going to present is maybe up here where it's just start to begin and just have perhaps accumulated. So the purpose of this study was to investigate the early phase of unilateral tendinopathy in both the Achilles and patellar tendon in sports active individuals, mostly recreational athletes, but there was also some who were elite athletes, but for the most recreational. And we wanted to investigate the initial signs of the disease, pain and soreness in relation to physical activity. And this was performed in a cross-sectional design where we actually were looking into symptoms for either 1 month, 1 to 2 months, and 2 to 3 months. And there we investigated tendon morphology, ultrasound, MRI was used, and mechanical properties, and tendon vascularization, Doppler, and so on. And then biopsies was also taken to look into inflammation and pain, and also structural proteins in those samples. So, and then we wanted also to correlate these findings to the disease duration. So, with regards to the material we had or were able to recruit, there we were able to recruit 200 people with tendinopathy, and both Achilles and patellar tendinopathy, and you'll see later how many there are in each of the groups. But also we had a matched group of healthy controls. But as you can see, some of you, that those who had tendinopathy were actually a little bit older. And that was not really intended so, but we tried to match in a way that they were having their preferred training partner in the that was included, sorry. And thereby it was just a coincidence that those who had tendinopathy was a little elderly and also had a little higher BMI. So, and then you can see also that the training experience is around 10 years for those who have tendinopathy, and a little, that's not significant, it's a little lower on those who are around 7 years. Good. So just to go into the methods we actually used was the tendon dimensions. It's going down this one. Can you just help me? Okay, sorry. Okay, thank you. Yeah, sorry. So we looked into the tendon dimensions and also looked into the blood flow, and there we used MRI to investigate the tendon cross-sectional area. Here's the Achilles tendon, and also into the patellar tendon. And there we also measured the width, and we also looked into the thickness of the tendon. Here are some examples from the measurements of ultrasound, and here's the where we are looking into the thickness, and also where here we are measuring the ultrasound Doppler. And we also looked into the tendon mechanics, and some of you know this setup that we have having at Bispebjerg Hospital, there where we actually are, the persons are performing a ram contraction, and at the same time they are been measuring by ultrasound, so we can actually measure the deformation of the tendon, and also we can measure the force at the same time. So in that way we can then generate a curve, a force deformation curve, and thereby we can calculate the mechanical properties here for the patellar tendon. And we also took biopsies to look into turnover and growth and inflammation, and then we I want to say that we also have a presentation later today with Michael Kerr and Niall Miller about the inflamed tendon, and I want to encourage you to go to that session and hear more into detail about these data, especially on this topic. But I will briefly go over it later. So the findings here for our patients on Achilles and patella tendinopathy, as you can see, this is the findings on how much pain they had, and this was the scoring for their activity, average activity, sports activity, and as you can see, there's not much of a difference between the different time periods. So, and that's also true for that was the first one here was Achilles, and this is the patellar tendon. Yeah, so for the dimensions, the results for the dimensions, excuse me, there we can see that there's a much higher, much greater cross-sectional area in the tendinopathic patients here for the Achilles. And here you must see that this is on the measured so that the results is compared to the control tendon. So this is the percent-wise greatness of the tendon. So this is much higher, as you can see, for all time zones, and it's also much greater compared to the healthy controls. So, and that is also true if you look into tendon thickness. We have a lot higher tendon thickness also. And that seems also to be true to some extent for all the time zones, but only at the late stage we have a higher or a greater width of the ultrasound. But looking into the MRI, we must say this was only performed at the affected leg. There's not much of a difference between each time zone. Yeah, so for the patellar tendon, it's more or less the same picture we have. Maybe there's a little more in the later stage, but again, the picture is more or less the same as I said, compared to compared to the Achilles tendon. But again, when we look at the MRI data, there's not much of a difference between each of the different time zones. So yeah, so let's move on. And when we look into the Doppler data, then you can see that there's a clear picture of much more Doppler in the affected tendon compared to healthy controls, and that seems also to be the case in the different time zones. So, and also, of course, compared to the other leg, as they are their own controls. Good. So, just briefly going into, as I said earlier, in the biopsy data, here the take-home message is that there was a lot of things that was measured on, as I said, on turnover and growth here in this case. And the only one who actually showed a positive result was on TGF-beta, and that was in the end stage at 2 to 3 months. So that could indicate that it's more upregulated in the end of this, in the early phase of tendinopathy. And looking into to the information on, and here in this case, nociception, cell stress, and inflammation, there again, there was only substance P who was increased in the later stage to say 2 to 3 months. So there was not any of the other data who was actually positive for angiogenesis and autography. So, but as I said, I will encourage you to hear Michael's talk where he will elaborate on these data. Okay, so then looking into the results of the mechanical stiffness for the patellar tendon, here you can see there's barely any, or there's not any kind of change and with the mechanics compared to, and in this case, this was measured against the control tendon. So no change at all for the different time zones for the patellar tendon and compared to the controls. So in conclusion, there seems to be a tendinopathic Achilles tendon cross-sectional is determined by a higher cross-sectional around 25% compared to healthy controls. And both Achilles and patellar anterior-posterior diameter, or the thickness, was also greater, but in the later stage, it was most true for the Achilles tendon with the width. And so the size seems to be greater, and that accompanies also the hypervascularization, which is much greater for both patellar tendon and the Achilles tendon. But there was not any change for the mRNA angiogenic factors at all. And again, for the biopsies, the mRNA for most growth factors and tendon components, this was unchanged, but only the TGF-beta was positive together with the substance P here in early tendinopathy, of course. So, so this, or the take-home message here is this is the first data on tendinopathy, and we can see that there's a gradual increase in angiogenesis, and there's also an increased tendon size, and that also seems to see there's some tissue anabolic and catabolic signaling to be increased, but not only for a few factors, and the mechanical properties seem more or less to be unchanged here in this phase. So tendinopathy seems to be a pathogenesis of disturbed tissue homeostasis with some fluid accumulation in response to repeated overloading. So thank you very much.
So my presentation will have a more clinical approach, and it's based on experience gained from 2 studies on early tendinopathy conducted in our department. So the first study was this one performed by Tran and others, the study that Christian just talked about. And in this study, we included 200 sports active participants with early tendinopathy. And the second study that I will tell you about is an ongoing study, so it's unpublished data that I will show you from this study. It is conducted by Malmgaard Clausen, and in this study, we included 69 sports activity participants with early tendinopathy. And common for the 2 studies is that they all got the same physiotherapy instructions. So the characteristics of these patients we know from the study Christian just talked about. And here we know that we had 200 sports active participants. They were around 38 years old, and they have all been practicing sport for around 7 years. And weekly they trained 7 to 8 hours. Out of these 200 participants, 44% of them were runners, but we also saw a lot of other different sports represented. So all in all, in these 2 studies, I saw almost 300 participants and gave them all physiotherapy instructions. So opposite to patients with chronic tendinopathies, most of these patients still had a rather high activity level, and therefore we didn't want to load them too heavy and ended up with these set and repetitions that I have described here. So they were all performing the exercises for 12 weeks, and they performed them 3 times a week. And we gave them 2 Achilles exercises that I will show you in a minute, and 2 core exercises. So the first 3 weeks, they were doing 3 sets of 15 repetitions, and then from week 4 and the remaining weeks, they were doing 3 sets of 10 repetitions, but with more load. The core exercises, they performed the same amount the whole period. So since they should be able to perform the exercises at home, we ended up with these 2 exercises. So we instructed them to do modified heavy slow resistance training, and the way that they could adjust the load were by performing the exercises standing on 2 legs, standing on 1 leg, or by putting some load in a backpack. So to target the gastrocnemius, we used the first exercise, and to target the soleus, we used the second with the bent knees. And they were all shown these 2 exercises as well, and that was to strengthen the hip stability and the muscles around the hips, and balance and stability over the hip and knee and foot. The way that they could progress the load here was by using an elastic band with more resistance. So they were also all guided about load management. So we recommended them to follow this pain monitoring model, as many of you probably already know. And according to this model, 0 equals no pain, and 10 is the worst pain that you can imagine. So we regarded the green zone, the zone between 0 and 2, to be the safe zone, the yellow between 2 and 5 to be the acceptable pain zone, and the red zone between 5 and 10 is the high-risk zone. So we told all of them that they were allowed to continue the exercises, but we recommended them to stop activities that would lead to pain in the red zone. And then they were told to focus on not only the pain during the activity, but also how the pain was the following day in the morning. And we were happy if it was between 0 and 2. If it was more than that, they should think about what they have been doing of activities and maybe reduce the activity. So what do we know about how much they were following our advice and they were doing the exercises? From the second study I told you about, and this is unpublished data, so this is preliminary results. From this study, the patients were randomized into 2 groups. So we had one group getting NSAIDs for a week, initial after 12 weeks, and one group getting placebo in the first week. So from this study, we know that they had 36 possible training sessions, and out of these, they performed 26 or 27, and that equals 74%. And actually, we thought that was pretty good. So again, this is preliminary data from the same study. So a way that we evaluated the severity of the Achilles tendon pain was the VISA-A score. And as you can see here, we have the blue bar indicating the placebo group, the red bar is the NSAID group, and these 3 time points, that's the first is the baseline, so the second is after 1 week of NSAID or placebo, and the third time point is after 12 weeks of training, and up here you have the VISA score. And as you can see, we found no difference between the group, but we saw a significant improvement in both groups from baseline to follow-up. And the same pictures we saw regarding the pain. Here the patients were asked to do 25 vertical jump on one leg and then report the immediate pain afterwards. So again, blue is placebo, red is the NSAID, the time point is baseline after 1 week of placebo or NSAIDs, and then after 12 weeks of training. And as you see, we saw the same results in both groups, so no difference whether you were doing placebo or NSAIDs, but significant less pain after follow-up in both groups. So how do patients with early tendinopathy reply to physiotherapy in terms of load management and exercises? So we compared to patients with chronic tendinopathy, it seems that we saw a rather higher success rate after the 12 weeks. They were all getting better, and they were improving faster. And actually, most of them were also able to continue a rather high level of activity and still get better. It should be said that in these 2 studies, we didn't have any control group, so they were all doing physiotherapy because the aim of these 2 studies was not to show the effect of physiotherapy. So we do not know if they were getting better because of the physiotherapy or just over time. However, we know from other studies that chronic tendinopathies respond very good to heavy slow resistance training. So therefore, and based on our experience with almost 300 patients, we recommend a training program adjusted to the individual, and we also recommend focus on load management, and we didn't see any effect of NSAIDs initially. So now we would like to hear your experience with this topic, and we'll like to discuss it with you. So thank you.